you, Ross. It's a real pleasure to come here. Mahesh invited me. I was really thrilled because for all of us to come here and give a talk, it's always a privilege. The history of this place is amazing, and we know that clinicians and the contribution of this institution is always be considered, the top. Nowadays, a lot of unique work with Tava that is really, paving the road for us with new approaches for and decision making for AVRs and so on and so forth. I always say that, I think I did accomplish quite a bit in my own career when I look at my own expectations for myself, let's say 20 years ago when I started this journey. But I think my best decision was basically to take what Jimmy Cox told me and actually be very careful to change it and be consistent with it until I'll be convinced that other things do work better. And it goes to mitral valve, it goes to tricuspid valve, and mostly to atrial fibrillation surgery. So I basically didn't change anything. I learned from Jimmy Cox that maybe a deficient part of myself, but of my career, but we'll talk about it in a second. Now, this talk is meant to, I think, make us think about the problems we are facing. So there is no good solution for atrial fibrillation. Let's say there is no perfect solution for atrial fibrillation, and we're still struggling around it, both from the EP side, from the surgical side, and definitely from the medical side. So let's just go over some of the aims of this talk. Well, so first I want to discuss maybe some thoughts about the mechanisms of atrial fibrillation and how important they are when it comes to lesion set and decision making about that, and then also to point out some of the existing gaps with technology and safety and efficacy of procedure, especially when it comes to surgery. And then the last minute aim, I think it's important to discuss this paper every time because I think this paper is doing disservice to work of a lot of people in the field. And this is the New England publication with Mark Gillenor as the main author, who is one of my best friends, but we had a lot of heated discussion around this paper and how it came about, and I'll spend a few minutes just to show how this paper is problematic and basically reflective of what we are facing today as challenges. So what are the mechanisms, what mechanism of AF? So this is a seminal paper, and I remember reading it in 1998 in the Journal of Medicine. Hessinger was a really brilliant, almost on the level of a philosopher when it comes to arrhythmia in general. I mean, he's really unique in his thought process and his understanding. And he basically came and said, relatively speaking, it all starts within the pulmonary veins. What is the pointer here? The middle one? Oh, here it is. So let me go there. It all starts within the pulmonary veins. Now, this kind of shocked us because Moore theory and Jimmy Cox's theory and Bueno theory was that it's multiple wavelets and reacted circuits and so on and so forth. So how come it is so simple? Well, there are some explanations. The problem is that about a year later, Hans Cook, who is also a very good electrophysiologist from Germany, came with trying to mimic this model and found that this is really not true. There are at least 1/3 of the foci, so to speak, outside the pulmonary veins. So, are they wrong? No. This is one of the problems with mapping. It's all about mapping, the tools you map with, and the perception of what you see, because it's a lot of interpretation, and I'll get back to it in a second. So, when you look at the guidelines, HRS guidelines, Heart Society guidelines, these are the mechanisms that they suggest for atrial fibrillation. And when I first looked at it, I said, well, this is a joke. I mean, we really don't know what it is. And how come we have, so many mechanisms and so on and so forth? And so I'll just make one point now and I will return. I think that part of the problem is that we don't map the same patients, meaning not the same patients, it's obvious that you don't have the same patient, but some patient had 5 ablations and they are being mapped, and their mechanism for AF is being recorded, and some patient never had anything done to the atrium and they are being mapped. So some of those mechanisms that we see here, we map the failures of ablation, because we know that any ablation is a source for arrhythmia if not done appropriately. I think this is part of the problem. But we really don't know, and I always go back that, the perfect double-blind study is 2 cardiac surgeons trying to analyze an EKG. So we, cardiac surgeons, we really don't know anything about all these things, so I try to keep it simple. And going back to some explanation of mechanism, this is a paper from Boino himself and Rav Damian from St. Louis. This is a 10 years old paper, and what they were able to show is basically that you have dominant frequencies that are both in the right atrium and the left atrium. As I see, this is before the new nomenclature of atrial fibrillation, when we also only had paroxysmal and chronic, and WPW is irrelevant here, but you can see that in some cases there are none, but especially with chronic atrial fibrillation and paroxysmal atrial fibrillation, you have dominant frequencies in both atria. But what's more important in this paper, I think, is that it's variable. And that means that it's an ever-changing model, and I'll get back to it in a second. The same with Rudy from the same institution who is developing this non-invasive mapping that shows that basically it's multiple wavelets, it's probably not just focus, and more importantly, the more you have AFib, the more complex the model is becoming. And as you can see here, that with long-standing persistent, which is the equivalent of chronic atrial fibrillation in the new nomenclature, so to speak, you have much more complexity, as you can see by the complexity index. But also persistent is quite complex. So paroxysmal, and especially paroxysmal that short term, is probably a fairly simple, straightforward model, and maybe we can do stuff that can stop it fairly easy. But the others, I'm not quite sure. So you can see here another paper saying the complexity goes with longer clinical history, and therefore it is probably a biatrial problem, and we have to be careful about it, because if we go there, especially with a long-standing and someone with long-term atrial fibrillation, every cell of the atria can start atrial fibrillation in theory. So it's not just a pulmonary vein. This is a work that I'm very proud of, collaboration with a brilliant group of scientists that left the NIH, Chip Patrick and Lance Liotta, where we look into basically mitochondrial dysfunction in patients with atrial fibrillation. And this is actually a source of a grant that we're probably going to get another one grant. And what we found is basically that there is more to the story, but what we found is that the AFib patients are fundamentally different from non-AFib patients. We biopsied the atria in multiple places, we isolated mitochondria, we did a global proteomic, and then we did a reverse phase protein array to verify. And basically, without being too detailed about it, because we can talk just about this work for about 2 hours, I think, you can see that there are, by the heat maps, there are different manifestations of proteins and activity, both in the left and the right atrium when you compare patients with and without sinus rhythm. And basically, we were able to identify abnormal pathways that are associated with atrial fibrillation, basically glycemic and lipogenic pathways, which we think may shed some light on why the ionic channels are so disturbing different arrhythmias, because it may be only dependent on energy supply to the cell and not anything else. But this is speculation, and hopefully the grant will kick in and we'll have some answers. But What's interesting here, beside the finding, is that it doesn't matter where we biopsy the patient, the mitochondrial dysfunction was showing the same trend. So it doesn't matter if it's the left atrium, it's the right atrium, it doesn't matter where it was. It's kind of a systemic problem, and I think this goes back to what we showed with Rudy's work, that it is more complex when you have a lot of tissue remodeling. So going back to this, I now put a question mark because I said I don't understand this, and I don't. Nobody does, because we map different patients, we map different patients without ablation, with ablation, and therefore when you go to the maze concept, and this is the original, one of the original drawings of the maze, which is a cut and sew, as you can see, it's basically showing you that you know, the lesions are kind of incorporating whatever mechanism you have and contain it within the back of the atrium, and when it goes towards the appendices and the coronary sinus, you have lesions basically everywhere, and I'll get back to it. So the maze procedure is not based on anything sophisticated while we are doing it. It's basically an anatomical approach. An anatomical approach. And I think this is important because let's see what others are doing, or try to understand what others are doing, because this is really not intelligent. I mean, why would you do a maze on someone who has maybe pulmonary vein foci? I think that pulmonary vein foci is what you see at the time you map. But if you map the same patient 365 days a year, are you going to see the same mechanism every time when it starts AFib? I'm not so sure that this is the answer. So let's see what characterizes it. So we spoke about atrial remodeling, mainly duration, and duration is becoming now the most important variable in our prospective work in prediction of failure of any intervention. It's probably not a stable model. We said it's probably biatrial, and in some patients, any part of the atrium may start atrial fibrillation. And we have no ability to predict it in a given patient, because what we see in the cath lab or in the operating room or wherever we are is a snapshot of what we see at that moment. And ablating today's mechanism may not be the reason for tomorrow's failure. So we go back to Choluteca. I hope I said the same, the name okay. It's in Honduras, and this is a fascinating story. So that town in Honduras basically has this bridge, and the bridge was destroyed by hurricanes every time, and caused a lot of, you know, hassle and devastating results, you know, because things were disconnected. So the Japanese came and built this building that can sustain hurricane, whatever grade it was going to be. 5 is what we are counting, but you know, probably 10. You know, it's a good Japanese bridge. And then came Mitch in 1998 and dumped about, I think, 37 or 40 inches of rain over that area, just sitting there for a few days, as you know. And basically, this is what happened. So the bridge sustained, but the river moved. So I think this is what happens a lot of time when we map and ablate, when we try to be sophisticated and smart. Now, I know this is not the entire truth, but I think I always, when I do a maze procedure, I think about this, because I don't want the problem to move to another place I wasn't there. This is why right now, the biatrial maze procedure, which is an anatomical approach, may result in the best results, but may not be a long-term sustainable solution because of things that we will talk about. So, the perfect catheter ablation is an anatomical approach. So, EPs throughout the world do map, but at the end, what they try to do is to mimic the maze procedure. Most of them, I mean, there are different schools, and some of them will claim that this is the perfect ablation for the left atrium. So why map if this is what we want to do? We'll be quicker, we'll be faster, if we'll have good ablation, catheter ablation technologies, and we can mimic the maze, with a catheter, this would be the perfect solution. Well, some would not agree with me, but I think that it is maybe that the problem is moving around and we need to do something about it. So this is just a repetition. So these are the challenges, and we need to basically look at this in a different way. So we didn't mention this again, but this is an up-and-coming approach to treat atrial fibrillation, which is a hybrid approach. It's endo-epi approach, surgeons and electrophysiologists. And there is no one approach yet, and there's some criticism about it. But I think this is probably where the heart team approach and a collaborative effort will result in the most minimally invasive approach when it comes to surgery, and the highest success rate when it comes to those patients with long-standing persistent large atrial and so on and so forth. But the advantage of the hybrid approach today is we have imperfect tools to perform the hybrid procedure, both in the EP side and the cardiac surgery side. But the advantage is that it's being done in a very controlled environment right now under studies, and we are able to study our failures. And maybe by so doing, we will improve our ability with next generation devices and maybe modification of devices. So why the concept works? Simply because, remember the mechanism I showed you. This is a MACE procedure we do today without cut and sew. It's basically a biatrial approach. It may be an overkill in some patients, but it's designed just to basically not to prevent atrial fibrillation from start, but it wouldn't let it be maintained in most times, especially if those lesions are all transmural and being done appropriately. And that's one of the challenges we have on a daily basis. There is a wide variation between surgeons. One example, the QAF study was a study that Medtronic were running, and we were one of the centers in that study. And the results of the same lesion set, the same tools for ablation were between 0% success rate to 100% success rate at 1 year. Same lesion set, same devices, different centers. Surgeons need to be trained and educated, and this is true for everything we do. So the current gaps are basically guidelines and lesion set, training, basic EP for surgery, and surgical technique, and technology. Because basically, this is a true statement. There are no consistent unidirectional ablation devices, both for all and non-bypass procedures. We ablate, we think we are transmural, but there is no way we can test it reliably. Except maybe around the pulmonary veins, but also it's an acute testing. So certain areas like the mitral valve isthmus are very difficult to be ablated, and this is another challenge we have both when we do on-pump and off-pump. Let's just spend a little bit on this paper and just to show that we have to be really careful with what we read. Surgical ablation of atrial fibrillation during mitral valve surgery. Well, you think it's mitral valve surgery only. Actually, most of the patients that were in this case, in this study, were mitral valve surgery, CABG, mitral valve AVR, mitral valve tricuspid, triple valves, and so on and so forth. So it's not just mitral valve surgery. The aim of this study, basically the major aim of this study was to prove that if you do nothing, as opposed to do something, it's better to do something. Ablation. And I'm saying something because nobody really knows what was done here when it comes to lesions, because the variability among the centers, some of the surgeons here are brilliant. I mean, they're very good surgeons, but none of them most of them were not really educated about the MACE procedure. And I'm about to write a paper, by the way, on 68 operating rooms in the world where I basically trained physicians to do a MACE procedure. Some of them knew how to do a MACE procedure, and except for one place in Sweden, nobody actually did the MACE procedure as was designed by Jimmy Cox. They all had their interpretation of the procedure. So they say that biatrial MACE is not better than uniatrial lesion set, but it was never powered for that. It was a subgroup analysis for left atrial versus not, but it was underpowered and it was never in the main aims of the study. It was a secondary outcome of the study. And basically, there are a multitude of problems, especially with the lesion going to the mitral valve. It was that there are a lot of different energy sources, unidirectional cryo versus not. This was a problem. I don't want to go through it. Although in the method of the patient, the paper, and not in the index of it, they said that basically cryoablation was the only device used, but that's not true. They used all kinds of devices there. The other thing they did, they had a very high rate of pacemaker, close to 20% when they did right atrial lesion set. Now, we are publishing a paper with close to 1,000 patients full MACE procedure with 6% pacemaker rate. But when you look what they allowed at the discretion of surgeon to add an isthmus line on the right side, which is a carbo-isthmus line in order to the tricuspid valve, which is not allowed when you do a MACE procedure because then you basically separate the atrium into 3 pieces. That's not part of the MACE procedure. So what happened is that they created this and basically created the atrium and passed it into three pieces. And if you look, the indication for pacemaker is mostly AV block. It's not really AV block. It's simply the right atrium was completely passed and could not conduct into the left atrium. And also the corridor was not maintained. This is how you do right-sided lesion sets. You take into account the sinus node area and the sinus saccade area, and you maintain enough corridor for the conductions to move around, and you don't do anything in this area down here. That's a MACE procedure. When you do it this way, your pacemaker rate is only 6%, which is exactly like when you do multiple, and I'm not talking about isolated MACE. For isolated MACE, our pacemaker rate is about 1.5%. This is with patients with valves and all those other things. So the devil is in the details. When we read it, we cannot distinguish it, especially if we are not in the field of cardiac surgery. But when we cardiac surgeons that know one or two things about it, read it, we are beside ourselves because we are shooting ourselves in the foot. Biatrial lesion set is working very well. Complication is not high, but you need to know how to do it. You need to use the right tools. So, but they did find that if you do something, it's better than to do nothing. Which is, that's why they did this paper. That's the only thing that they should have published. That if you ablate, you have, at 1 year, 63% success rate. Now, the way they define success is different than the HRS guideline, which is a problem. But let's not get into it, because success may be much higher than what they show it. And this is the 2 lesion set that were underpowered, that showed that pulmonary vein isolation is as good. And what happened? Most surgeons in the world, because this is probably easier and more straightforward, say, oh, we don't need to do a MACE procedure anymore. But that's not the message of the paper. Gileadov himself showed that if you do it appropriately, you basically get a better success. And we published a meta-analysis that showed that unilateral versus bilateral is much different, much better to have a bilateral lesion set. So what about left-sided? Left-sided is good, and I'll just go very quickly because I don't want to get too much time. This is a paper we just published in the Annals of Thoracic Surgery, and if you look at predictors for failures, which are age, size of the left atrium, duration of atrial fibrillation, type of atrial fibrillation, those are the 4 ones that predict failure. If you have 0 predictors for failure, I mean the groups are small, but I think the paper is important, then success rate can be significant. I mean, look, 24 months of antitherapy drugs, 91%, if you do just left atrial lesion set with 0 predictor. But look what happens if you have 1 or 2 predictors for failure, it drops to 70%. Now, 2 years is very short follow-up. We need to look even longer because it keeps dropping. I can tell you we have some follow-up on this data, it keeps dropping. And the predictors for failure are mainly the size of the left atrium, and the age of the patient. So older patient actually, one-sided lesion set is not as important. So left-sided lesion set can be applied. We need to do a prospective randomized study, and now with the help of Atrial, we're actually putting together with Damiano an international one that's going to be very, very controlled with authorship and so on and so forth. So we know biatrial lesion set versus unilateral lesion set in the setup of mitral valve surgery. So we're going to redo the sets, the New England Journal paper study, and hopefully get the appropriate answer. And it may be that the MACE procedure is not better than unilateral lesion set in this setup, but at least we know what was done, it will be standardized, and then we can make sense out of it. And we know that doing prospective randomized study, the devil is again in the details, how you select the patient, how you make sure that everybody is getting the same, and so on and so forth. So hybrid procedure, I think hybrid procedure is a big step, and we actually did the first prospective randomized study on hybrid procedure back in 2008, 2009. We stopped after 19 patients. Why? Because we already achieved the primary endpoint, which was bilateral lesion set on bypass is better than hybrid procedure. What have changed since then? Well, there's a lot of experience with hybrid procedure, and there are some tools and some understanding of mechanism of failures, but it's a work in progress. So I think it's a good thing in various ways, involving of surgeons, creating a heart team, more cases, which is good, always good. Suboptimal outcome is very bad, because the last thing we want is to take something, a very good concept, and say, oh, it's not even better than catheter ablation, and I'll show a couple of examples, and basically you have to have supportive EPs, because if you become unsupported, becoming divided institution around a very important topic. So one example of bad hybrid procedure, this is a convergence procedure, and there is more to the story here. It came from Texas, as you see, with Natale and Edgerton. And basically, they compare convergence to catheter ablation. Now, convergence being done differently today, and maybe a little safer, but look what happened here. They had really very, very high rate of major complication rate, and actually 12.5% of procedural mortality. I mean, just to put perspective, we treat atrial fibrillation mainly to treat symptoms and maybe prevent strokes in the future. We cannot have deaths. We cannot have strokes, although we all have strokes, with EP ablation as well. And 12.5% mortality is really like, even take the sickest of the sickest patient, I don't think we have this mortality today. I mean, aside from heart failure, valves, complex valves, and so on. So I'm talking about bread and butter cases. So this is a bad example of a hybrid procedure. And then look what happened. Catheter ablation was superior in the outcome when it comes to rhythm only. So we all took note about with this paper, and I think this paper was circulating around until it was published, because Jack, although I accepted it as a review because I thought it's an important message, rejected it, and at the end the paper resurfaced and was published just a year ago. But this is an example of how things should not be done. So hybrid is an excellent concept. The amount of work, the amount of talent in the same room is big, but we have to take advantage of it. Also, problems in incomplete box in 60% of the patient when it's done, off bypass, which is requiring repeated ablation or suggests failure in the future. And as you can see, if you do it staged or not, you're betting probably about 60% success rate every year, which is suboptimal, because some of the catheter ablation alone can do it. But I think the hybrid procedure is a winning concept, and it's a moving target. So we did this is a paper by one of our fellows from South Korea that was published in the European Journal that basically looked into hybrid versus off-pump cases versus endocardial studies, which you see not too many, to look at safety and efficacy. And as you can see, patients are kind of similar, although the endocardial one, the full MACE procedure, much more advanced atrial fibrillation when it comes to percentage. But I think what's important is to show that endocardial, when it's done, by experienced centers, had the best mortality and the best complication rate, actually. So it's an on-pump procedure compared to off-pump procedure, was much safer in this study. And look at the results at 1 year of medication. The on-pump procedure was way superior to the other ones. So if off-pump procedure is being done, it needs to be improved, because right now it's lacking the results. It's lacking the safety in some cases. I'm not talking about just one or two experts that are doing it repeatedly and so on and so forth. So we have a long way to go to put a hybrid procedure, heart-ring concept into work that's going to really impact the field. But I think that's the way to go. So these are guidelines for the AATS that we're going to publish soon, and I think right now this is our guidelines. So it's a 2B indication right now for hybrid procedure, 2A for beating heart, pulmonary vein isolation for paroxysmal atrial fibrillation, simply because there are two prospective randomized studies that show the efficacy over even catheter ablation when it comes to success, and more importantly, we do not recommend the use of unipolar unidirectional radiofrequency ablation outside the clinical trials, as its efficacy is questionable. I think this is a message, and we are discussing it with the industry. We need to work on those devices to be more reliable, because it's not enough to put a line. We need to make sure that the line is consistent with what we need to do. So this is an older data. We already have 140 patients, and in this long-standing persistent paper, non-paroxysmal patient, that we did a full MACE procedure using a 5-centimeter incision on pump. And this paper is under review now with the Journal of Heart Rhythm Society. It has very good follow-up, up to 5 years, with a reasonable amount of patients. Now, I just want to show you that these are the complications we monitored, okay? So prolonged ventilation, 4% over 24 hours, 1 pneumonia, we didn't have any stroke, we had 1 TIA, and we can talk about it afterwards. Reoperation for bleeding on a patient we documented, was a redo, documented sensitivity to protamine, so we didn't give him protamine after the case, and we took him electively the next day to evacuate a big chest wall hematoma from the. So it wasn't like he had any bleeding source. Very low transfusion rate, either any transfusion or red blood cells, no renal failure, median stay of 4 days, but I can tell you that now we are down to about 2.8 days. And there is a mistake in readmission. It should be 5 patients, mostly for recurrent arrhythmia, and no death at 30 days. So is it perfect? No. But it can be done in a way that it's safe for the patient and basically give them this type of results over 5 years. If you allow any antithyroid drugs, it's a 90% success rate at 5 years. It's actually a little higher when we reanalyze with the full 140 and a little bit more patients at 60 months. And 80% of medications. Now this is with a single intervention. And when you look at the failures, half of the failures had events only between 30 seconds and 5 minutes. But 30-second event is a failure by the HRS guidelines. So the clinical success is higher because the burden of AF is much lower. Again, 80% of these patients have long-standing persistent atrial fibrillation. Now when we start to use the new probe, I actually don't believe that these results are going to be sustainable, but we started to use a new probe, which is a stiffer probe, a cryo probe, and we said we don't really recall failures when you measure it, not longitudinally. We have some recurrence that, because it's a moving target. Today in AF is not tomorrow in AF if you cardiovert or start medication. But we have 96% of medications at 2 years. And I don't know if this is going to be sustainable, but this is new technology that basically allowed us to have better tissue contact with over 80% freedom from any intervention, cardioversion or medication, not catheter ablation at 2 years. So comparing our results to the results of hybrid procedure, if you take the 1 year mark, then you see it's pretty much a work in progress. Hybrid procedure needs to do better. So we take patients, we put them on bypass, which is a big stumbling block because a lot of electrophysiologists don't want to refer patients to surgery that's going to utilize the bypass. But as I showed you, bypass is safe and if it's done appropriately. But this is even more important. This is survival 10 years of this group of patients. Obviously, not so many patients at 10 years. And this is even more important. This is the freedom from stroke at 10 years. Basically, we eliminated strokes. And this is in lieu of the majority of patients being off anticoagulation. 84% of them are off anticoagulation at 2 years. And basically, as you can see here, not appropriate, meaning that we thought they can come off anticoagulation, but one of their primary cares or electrophysiology or cardiology, they didn't think they can come off. And 14% of the patients remain on anticoagulation, either because of recurrence or they had other indications for anticoagulation, such as DVT, hysteropy, and anticoagulability, and so on and so forth. So just going back, this is the freedom from stroke at 10 years, when it's being done appropriately and the appendage is excluded and so on and so forth. So in summary, I think that off-bypass standalone procedures are the majority of procedures being performed today, but there is some gaps in technology, gaps in safety, gaps in success that we need to work. Post-treat RCTs are really important to maximize our ability to understand where we go and wrong and avoid poor results, establish decision-making process on all those three, on-pump, left atrial appendage management, and off-pump. And surgeons should be familiar with all of these objects, variables that are associated with the success. I think this is saying that we learned a lot, but we still have to learn way more in order to perfect our technique and minimize our intervention. So in 2015, I think MACE concept is the only one that reliably works for patients with at least long-standing persistent atrial fibrillation if done appropriately. And we need to focus on training and innovation. And AtriCure that have really representative in this room are really dedicated for surgical ablation. And in 2011, they started the training program, and most surgeons that are going through it at least understand what's need to be done. And I think we started to move the needle when it comes to more surgeons doing the right thing. And I'm not talking about just doing a MACE procedure. Understanding that a lesion is not the click of a clamp and push on a pattern. There is more to it, and this is important. And I like this. I like these two slides, and I've used it quite a bit. In the Western world, we don't like a standing stone because it may gather moss. So a rolling stone gathers no moss. This is an old saying, from the first century, before Christ. But moss sometimes can be beautiful. So we need to be very, very careful when we try to move things too fast. We need to understand, and I think the more I do, I feel, the more I respect it, and the more humble I am when it comes to what I say to patients and what I promise, and so on and so forth. So I want to thank you for your attention.